Hi, everyone. This is our midwifery practice protocol for normal labor, delivery, and the immediate postpartum. So, in early labor, these are the things we're looking at: the people in attendance, a doula, a partner, if applicable, birth documenters, people who might be taking photographs or videotaping, family and/or friends. There's going to be support and comfort measures that we're going to encourage, such as nutrition, hydration, elimination, different positioning and changes, looking at pain, emotional support, and hoping for adequate rest. The contractions are going to be about 5 minutes apart, lasting 45 seconds, and the strength will be mild intensity, but doesn't require full focus, although it might take your breath away at times. Cervical exams will be done after about 4 centimeters dilation to check for effacement, station, to check the bag of waters, see if they're ruptured or not, and for fetal sutures. Us as midwives, our duties are to review the following details: their medical history, any allergies, if this person is GBS positive, making sure that they don't have a penicillin allergy for antibiotics, and if they do, that we have an alternate available. Review any labs, the birth plan, and the gestation of the baby. We're also looking at the fetal status, which is using Leopold's maneuvers, looking at presentation, the ultrasounds, any sutures, and legal considerations that need to be made, and/or the fetal heart tones, making sure that those are within normal limits at 110 to 160 beats per minute. And we're going to check in. We're going to verify our plan, look at our coping ability, and our possible vitals. And have that continued client education and shared decision making: what to expect, when to call the midwife, what cervical exams entail and why we might encourage those, and when we don't encourage them. Communicating the findings that we find, any membrane rupture, antibiotics, and the importance of rest during this time of early labor, going into active labor. So for active labor, we have a couple things that we're going to be doing. We're going to be monitoring and noting your last intake of food. We're going to have your starting vitals for blood pressure, temp, and pulse. We're going to note your contractions, when they started, how timely they are, your intensity, and we're going to establish a baseline fetal heart tone. We're also going to confirm whether or not you are ruptured or if you have bloody show, as well as charting the admission and attendance of whoever is in the room. We're going to look at fetal position and evaluate appropriately for out-of-hospital delivery to make sure that this is still going to work. We're also going to document all people in attendance, us as midwives, as well as your doula, any friends, family present, and partner. We're going to look at our equipment and setup. We're going to have our recess equipment available and set up. We're going to have our birth kit, as well as prepare the tub. Depending on how far along this client is, we'll determine when we fill this tub. And we're going to set up a recovery resting space for the immediate postpartum. We're going to look at your contractions, the frequency, duration, strength, intensity, and how your labor is progressing. And with all of this, we're going to be monitoring the birthing person and the baby at all times. We're going to be monitoring your BP, your pulse, your respirations, and your temperature. We're also going to be looking for any vaginal bleeding that's happening over the course of active labor. For the baby, we're also going to be looking at those fetal heart tones every 30 minutes. Make sure that you are either SROM, AROM, and we're going to look at fetal heart tones to be within those normal limits of 110 to 160 beats per minute. Use Leopold's maneuvers to determine position and presentation of baby, check in any movement that's happening, and look at your input and output, your voids, BMs, emesis, if that's happening, and also calculate any food and or drink that you're taking in, as well as the color of the amniotic fluid when SROM and or AROM happens. So this is all going to be charted accordingly. So active labor continued. We're going to make sure that you have support and comfort measures such as hydration, nutrition. The hydration could be oral, it could be juice, water, milk, broth, probably not milk, it's a little heavy. And this also could be IV hydration as well. Want to look at your positioning, want to look at emotional support, perineal support, whether that's done by us with your permission or if you'd like to provide that yourself or your partner. Pain support ideas such as counter pressure, massage, heat or ice, audio, visual, or aromatherapy, if that's also using hypnobirthing, etc. Any movement that might be helpful, such as swaying, using the stairs if you have any, going on a walk, using your TENS unit, and the use of hydrotherapy, whether or not that's the tub that we've blown up or if that's your shower or your personal bathtub as well. Any cervical exams, we're going to be looking for pushing or progress, dilation, effacement, station, whether or not your bag of waters are still intact. We're also going to be looking at fetal sutures and molding on the head, the cervical position, and looking at visual inspection of the perineum. Any guidelines for hydrotherapy we'll go through, which is we want to make sure the water temperature is adequate. We don't want to make sure it's not too hot or too cold. We want to make sure we note when and how long you've been in the birth pool. If there's any fecal matter present in that birth pool, that we get that out of there. We can do vaginal exams in the tub, but if we're having a hard time really determining effacement and or station, et cetera, dilation, then we might ask you to get out, which is when to get out of the tub. There could be various reasons to get out of the tub, such as a sticky baby, potential shoulder dystocia, we're just not able to get a good grasp on baby, or the counter pressure essentially from the buoyancy of the water is making it really difficult to get that baby out. And then provide client education such as, normal progress, cervical findings that we find, SROM or AROM, what to expect there, the best time to get in the pool, verbal education such as the ring of fire, other sensations to expect so that when they do happen, you're not taken off guard. Listening to your body and the urge to push, the best time for the tub, transition differences, what those will look like, position changes and why we might encourage those, perineal compresses, again, why we might encourage those, and possible water delivery. If it's possible to have the water delivery, we'll explain why. If it's not possible, then we'll ask you to get out of the tub and also explain why that would be. So for the second stage, we've got monitoring, right? We're going to continue to monitor that birthing person's pulse, BP, temperature, verify complete dilation with cervical exams, any contractions, the frequency, duration, strength, intensity, and how labor is progressing. We're also going to continue to monitor the baby. We want to look at the baby's fetal heart tones every 5 to 15 minutes and chart those, make sure that everything is within that normal limit of 110 to 160 beats per minute. We also want to, again, provide calm support and comfort measures such as adequate nutrition, hydration, position changes if necessary, perineal support, whether that's a warm compress that we apply with your permission, or if that's something that you would like to do yourself or your partner, and breathing. We also want to use counter pressure, trauma-informed support, especially if this client has trauma in their past, any cold cloths that might be helpful, and breathing techniques. We want to, again, monitor that water temperature, make sure it's not too hot or too cold. We want to look at when and how long this person has been in the tub. And we also want to look at blood loss, especially if this baby and the placenta have been delivered inside that pool. We want to make sure that we're able to estimate that blood loss. We also want to look at the fecal matter, try to get that out as appropriate as possible, keep our butt down in the water if we're planning on having a water birth, and when to get out. If you've taken your butt out of the water and baby's head has come out, we cannot go back into water. So that would be one way that we would ask you to get out of the water. Client education and shared decision-making, again, cervical exams before pushing to make sure that cervical lip is gone, passive phase and delayed pushing, why you might encourage you not to push, pushing positions might be helpful, and the length of active pushing before a transfer, and any signs of shoulder dystocia and what that would mean. So for the third stage, we have placental detachment. We're going to have that big separation gush from where the placenta was attached inside the uterus. We're going to have the lengthening of the cord, a rise in fundal height, some cramping, and hardening of the uterus. With the delivery of the placenta, we have active management. We want to look at the cord traction, any medications, and fundal massage. Expectant management, right? We're going to be watching and encouraging maternal effort. We're going to be watching for that blood loss that's going to be happening while we're delivering that placenta, and encouraging the mom to maybe use gravity. So have them stand up, encourage gravity to help, as well as breathing and or small pushes, all while having the baby at their breast and chest to encourage some oxytocin to flow through them during this time. We're also going to be looking at placental expulsion and inspection. So if it was in water, we want to make sure that we have all of it, that we're visualizing everything. Dirty Duncan or Shiny Schultz. We want to make sure that this placenta has a 3-vessel cord. We don't look at the length of the cord as well as any abnormalities present. See if the membranes are intact, because if there are some big spaces where there's clearly membranes missing, that can indicate that there are retained parts. We want to look at the cord insertion location and the color, shape, and consistency, and chart all of these things. We also want to provide, again, support and comfort, such as we want to make sure they're eliminating, getting adequate nutrition, they're warm, and their baby is warm. They're guarding their uterine space, because that was just a very traumatic event. Any position changes that might encourage blood to come out and or clots from the uterine separation with the placenta, and any cord traction. We want to look at blood loss. If it's under 500 milliliters, it's considered normal, but we want to measure it by weight. We want to do a visual estimation, especially if this baby was born in water, as well as the placenta. We want to look at the fundal height, firmness, and location, as well as any medications to control hemorrhage, such as meso, Methergin, or TXA. And then we also want to provide, again, client education, shared decision-making about when to transfer medication to help the placenta, active management, and emptying their bladder. So for the immediate postpartum for the birthing parent, we want to, number one, look at hemorrhage monitoring and control. We want to do fundal height checks every 15 minutes, fundal location every 15 minutes. We want to look at the estimated blood loss every 15 minutes, placental checks immediately after. And we want to make sure if this person is Rh negative that we take a cord blood sample. We then want to do their vitals and labs. We want to check their BP every 15 minutes in the immediate postpartum for the first hour. We also want to do their pulse, their temperature, and again, if they're Rh negative, make sure that their antibodies, we do the antibodies job before departure. We want to then do perineal care. We want to visually inspect the area to see what it looks like. We want to see if there's sutures needed, and if so, have a sterile setup and dissolvable sutures. We also want to document the degree of tear. If it's a 3rd or 4th degree tear, that would be reason for a transfer, especially if there is immediate bleeding that's excessive or we cannot stop. And also provide support and comfort in this as well, which is, ice as needed, herbs and tinctures, homeopathy, and pain medications if that's appropriate. We then want to provide support and comfort with nutrition and hydration, make sure that this person is getting their electrolytes and proteins back in their body, a shower if they feel like that would be great, valued parental time, giving them their little love bubble, medications for pain, homeopathy, voiding via the help of a peri bottle or a catheter, making sure they get that golden hour skin to skin with their little one, and an environment that is calm so that they feel that they can truly bond. And again, client shared decision making, a placenta tour if they'd like to see kind of what's going on and where baby lived for all those 9 months. Any plans for the placenta, if they're going to bury it, if they're going to put it in their garden, if they're going to freeze it, if they're going to encapsulate, any medications, how long until we leave as providers, and situations where we would stay longer if there was a transfer. So for the immediate postpartum regarding the baby, we first want to look at the fetal well-being. We want to do his APGAR scores at 1, 5, and 10 minutes. If NRP is necessary, we want to have stim, PPV, and suctioning available right away. We want to look at vitals for fetal heart rate. And we want to have temperature as well as respiration rates, and the glucose if over 9 pounds. We also want to do our newborn exam. This is done about 2 hours after birth, and we want to have our measuring tape, warm blankets, a scale, stethoscope, and any lab equipment and or medications. We want to look at their Ballard score, check their vitals, physical evaluation, so back and front of baby, any muscle tone and reflexes we want to note, and also parents' decision for vitamin K and or erythromycin eye ointment. Check their head, ears, eyes, nose, and throat, as well as an oral exam for ties. We then want to look at the condition of the cord. We want to make sure that the cord is clamped after it's done pulsing, have sterile scissors available, make sure that the parents involved, we are all on the same page if they want to delay that cord clamp until, if they're doing a lotus birth, et cetera, and also make sure that we know who is cutting that cord. We do not just make the assumption that we are cutting that cord. And then breast and chest feeding. We want to make sure that we have a visual inspection, look at that latch, look at the positioning of both the birthing parent, their breast and or chest, and that baby's positioning, make sure everything feels cohesive, and then provide support for any questions about nipple pain, comfort, cramping that might occur while breastfeeding or chest feeding. And then just make sure that they have everything available to them if and when they have any questions, and that we have proper references if they need lactation consultants after the fact. So discharge instructions for the birthing person, we want to make sure that their pain is managed, that there are no signs of infection, that their bleeding is under control, that they have a proper perineal care, and they're feeding frequently, as well as their breast and chest health and care is feeling adequate, and they're eating and drinking normally. For baby, we want to look at their feeding patterns as well. We want to make sure their temperature is regulated. We want to make sure that their breathing and respiration rate sounds good, and that they have a good diaper output. They take that big, long sleep after birth. We want to make sure that they have that and have developed maybe a small sleeping pattern. Look at their cord care, make sure it's nice and dry, bathing techniques, feeding, cues, frequency, duration, and lactogenesis. And then, of course, we want to leave our patients and clients with written and verbal instructions on when to call the midwife or when to go to the ER. To call the midwife would be signs of jaundice, signs of infection, fever, blood loss that won't stop, headaches and vision changes that just won't go away or get worse, upper abdominal pain, and leg pain. And then to go to the emergency room, these are non-negotiables. If you notice blue, core, or mouth in your infant, hemorrhage in you, lethargy of your newborn, not waking up to eat or feed, hard to rouse, and then distress that is not consolable, those are all reasons to go immediately to the ER. These are a list of the resources. Feel free to check any of them out. They were all super helpful. And thank you again.